She is, Dr. El-Chemali is the Associate Professor of Neurology and Psychiatry at Harvard Medical School. She's the Medical Director of the McCann Center for Brain Health and is also the Training Director for the Neurology Psychiatry Fellowship Program here. In addition, we have Jennifer Freeburn, who is going to be our discussant, and she's a certified and licensed speech language pathologist and has done her degree obtained from the MGH-IHP, the Institute for Health Professions, and her work is focused on cognitive-linguistic disorders arising from neurological conditions. And I'll let Zeina introduce our guest and our patient to present, but our topic, again, just thinking about, as we think about hope for post-acute COVID recovery in this era. So Zeina, please take it away.
Good morning, everyone, and thank you for having us with you this morning and for asking us actually to present. I would like to introduce Mrs. Anne Flaherty-Quimmer, who has been our patient for now almost coming a year. And she will have also the time to tell her own story in her own words. I thank you so much, Anne, for accepting to be a part of this grand rounds, and Anne will also share with you what she's doing in that space as well. So just because we are short on time, I'm going to start sharing my screen and basically to let you know that anytime you're going to see PACS, it's the post-acute COVID syndrome. This is how now it is pretty much defined, and that all the time since a year ago, we have been working as a multidisciplinary team. And even though kind of only Jennifer is here today, but we have also within that team, we have neuroradiologists, we have, as I will say later, the Benson Henry Institute, we have therapists that are doing cognitive behavioral therapy. So it's a whole team around that. Multidisciplinary sometimes might be a bit misleading. Patients think that they're going to come in and see everybody at the same time. I know that other models like at Cleveland Clinic or at Mayo, they might be doing this. At MGH, it is basically, it is not during one day, but then as patients, you go from one service to the next. And I have always done that in my work throughout my life. I mean, all of us can go through very, very bad stuff, no matter what we do. This is life, I guess, but we need to keep hope in everything we do. And I think this is what governs how I also render medicine. Okay. We have no disclosures to report. And with that, I'm going to tell what when Anne first came to us, what we saw, but then again, she will have her time to discuss. So Anne is a 60-year-old woman. She came in for us to the clinic for brain fog and fatigue. She worked as a nurse involved with discharge planning. And the first thing that happened was that she had noticed a headache at first. She went to get tested because she was concerned about the exposure on the job. That turned out to be negative. Kind of continued doing what she was doing, but then she developed fever, chills, body aches. She got retested. Almost a year now. After that, she got like really nasal congestion, the myalgia, the fever, the chills, nausea and loss of appetite, and a fever that lasted for a couple of weeks. And then she started to feel better. So she decided that I'm going to really take a walk and vacuum my house. And basically just after those two things, she found herself back to square one with the headaches, and then had many more days to recover. And then symptoms again went downhill from there. So she, at least from what we understood, that any like some activity, and this is definitely not her baseline, she's a very active nurse, very active person, doing the discharges. Everybody really looks up to her, and her team comes to her. But at some point after COVID, any activity, if it is not paced or if she had lacked sleep, then she would actually complain of fatigue and headache. That brain fog will come as a blank slate for her. She feels very fuzzy. And then it would take her, I mean, she would have the setback, takes her a few days, actually sometimes weeks to recover, and comes the cycle again. So she described her brain fog as in basically forgetting what she did. She would put down things and wasn't able to find it. At some point, actually, she went to the emergency room early on because she was on a medication, the Wellbutrin you will see later, and she did not know if she doubled up on the meds. I mean, this is pretty unusual for her, and she was worried about the side effects for that. If people were talking around her or multiple people asking her to do things, she found herself very hard to follow and think. That could last for hours. And when it clears, she felt better, but never back to baseline. She's a very resilient woman. I find her actually to be over the past year working together with a lot of coping with through praying, spirituality, walking, meditating, Reiki, talking with friends. She's very like proactive into wanting to feel better. She was absolutely certain that this is not the brain fog, for example, that at times she had from menopause, right? Those things were very momentary and then very occasional forgetfulness. She was never short of breath either when she remembered kind of that menopause. And also what is happening now is that she could go on crying spells despite having this positive outlook, and it would come from nowhere without any clinical depression or anxiety. So even at times when she was going through very stressful events, this never happened to her. And then came the time that actually, along with that, moving forward in the year, she was asked to go back to work. And like everybody else in the workplace, when employees were actually asked to come back, those who got sick got very anxious. She was kind of feeling the same, not only about the increased workload and the volume, but it's like where she's going to be seated, that she is going to be sharing her office with other people. All of that was in the work. She was told she cannot work from home. So when she saw us very briefly, she had basically, we do a bedside cognitive screening. She had lost 1 mark with her clock drawing, but as you also see there, even though she got the full points, her computation and kind of on the attention and on the sustained attention, where you would ask somebody to subtract 7 from 100, she didn't do that great. And for somebody with her a pre-morbid intellectual functioning, we would really have wanted her to give more than 18 F words and more than 16 animals. She's also very keen on really spelling and doing a lot of crosswords and spelling bees. So for her, that was definitely lower. So she got the workup that was basically negative on her vitamin supplementation, and the MRI of the head did not show much. She got referred to the Benson Henry SMART program, which is a program basically that uses a lot of the how to do the coping skills, including meditation, and to basically regain more that control over everything that is threatening from an amygdala that is basically all over the place, that tells you that you are stressed all the time. And with that, then increasing resilience. She went through neuropsych testing. I will let Jennifer talk about the cognitive rehab. We tried to restore sleep, which is very key in patients with PACS, with melatonin. And we addressed mostly this is what I was talking about, that system dysfunction that we find often in patients with PACS, even though the MRI hasn't shown anything. We tried bupropion because it gives her more dopamine, both basically for that attention and the focus, as well as for the mood. So I will let Anne talk at the moment, and I will stop sharing.
Good morning. So I think Dr. El-Chemali gave an overview of my symptoms, what that did for my day-to-day living. In early January, I was also feeling irritable and noticed that when I spoke initially, my words would come out jumbled, or the words that I wanted to say were not what came out of my mouth. And I had a hard time interpreting sometimes the conversation and what was being said, and my husband's dry humor, which pre-COVID I didn't get sometimes. But my life changed drastically. I was an independent and active woman. In the early days of recovery, I slept 12 to 14 hours a day. I was exhausted. I would describe the fatigue as being bone tired and multiply that 1,000 times. It's debilitating. Every time I did something, if I got up and I took a shower, I needed to rest. And it wasn't a rest for 15 or 20 minutes. I may have had to lay down for an hour. In the activity of daily living, making breakfast. If I ate, my husband had to take over all responsibilities for the house. He had COVID a week after I did. He recovered and returned back to work. But he did have to take over everything that I had done. I live in a 2-story home, and there's things that you take for granted that you don't think about. My bedroom is upstairs, our living area is downstairs with a bathroom, our laundry is in the basement. Going up and downstairs was very fatiguing, so I had to be very mindful of, if I'm coming downstairs, what do I need to bring with me? If I felt well enough to do the laundry, all right, what do I have to go do the laundry? I needed to make sure I brought everything down together. It was troublesome. I couldn't remember, I couldn't concentrate. I was grateful. I did not know about the Survivors Clinic. My husband heard Dr. El-Chemali on the radio one day at the end of January and called me and told me he heard her speaking. And I ended up referring myself. The diagnostic workup was described. I was grateful that I referred myself, but I will say that I was really terrified and scared of what might be found. So as the days went on, I just continued to rest. I had on my speech therapy. It was very socially isolating when I couldn't go back to work. The pandemic isolated all of us, but to all of a sudden think that I wasn't going to go back to work, and I missed that interaction with my colleagues, the patients, learning something every day. That was extremely isolating. I felt very alone. I have a very supportive family, and friends that would check in on me, and colleagues, and set up at Zoom, but it was to a whole other level. And during that time, there were not a whole lot of support groups for people who were not recovering from COVID. They were all online. I ended up joining a few of them where people would share their symptoms, what was working, supporting each other, and then joined a support group just for healthcare workers who became COVID long haulers. I started to recover over time. I can look back now and say I'm getting better, but probably until April, I didn't have a lot of energy. And then I decided I was going to try to go back to work. And that was before I had the results of my neuropsych testing. My manager was very supportive. I went back with accommodations. I worked 2 half days over 2 weeks. I had to take the train and not drive because I could be too fatigued to drive home. My walk from Back Bay to the hospital was not going to happen. I usually manage an assignment of 18 patients. I could only manage 2. When I looked at the Epic screen, I could not process all the information. I couldn't remember how to navigate around it. If someone gave me instructions, I had to write it down if it was multiple things. My colleague had asked me to see a patient, and she started to kind of spout off what she wanted me to do, and I had to say, stop. I need to write it down. The noise was bothersome. And I think one of the hardest things for me is that I look fine, I talk fine, but I'm not okay. When I went back to work, it was very humbling. I actually had to tell my colleagues I had cognitive deficits. I'm not the same Ann that left in December that came back in May. I wasn't able to do my job. I went back out on long-term disability, and then it took me from the middle of May until the middle of September to recover. I experienced a relapse of more severe fatigue and brain fog. I've continued to get better. I I'm able to volunteer for a pet shelter 1 day a week. I joined a Massachusetts advocacy group that I stumbled upon. It became important for me to educate people. I was meeting people in the community that had no idea what long COVID was. We met with our state legislatures and our senators to find out what they knew about long COVID, to educate them and advocate for legislation and protections for those of us who have been impacted. So it's been a journey. Recovering is a full-time job. It's something that takes every day I have to work at. I have to be mindful. I have to write down what I'm going to do. I have to take a step back and say, I'm planning too much. I can't do that. My life has changed in the sense family functions. We host a lot of parties. They start at 1 o'clock now. It's only dessert. It's not a full meal. Everyone helps. I have to come to the house and rest. And recently I was at my parents for a get together with my sister and brother-in-law and their puppy. And it was so noisy and too much for me. My sister said to my mother, I looked like I was on another planet that day. So it's a journey. It's up and down. It's not linear. I do remain hopeful. I'm resilient. I'm thankful. I practiced gratitude long before I got sick with COVID, and it's really important now. And I'm really grateful for every day that I wake up, my family, my friends, my healthcare team. I've always enjoyed the simple things. Sorry, but they're even more precious. You know, I have made new friends. There's friends I've made through the Massachusetts advocacy group. I've met another colleague who works at MGH, who's a long COVID survivor, who we're going to meet in person for a walk tomorrow. So I'm fortunate I've been able to surround myself with people, but this is my life now. My life is very different. I'm hopeful I'll make a full recovery and then I'll return to work, but when and what that looks like, I don't know. So I think.
All right. Well, thank you, Anne. Thank you for sharing and thank you for being present. And I'm sorry it also brought the tears, but this is because you're a very genuine person too. So you've always been that way. And we will remain all hopeful as well with you. I am going to continue sharing actually again my screen and to start from after we left off. So, all right. So I'm going to describe actually what we have seen over the past 18 months with a cohort of 100 patients that we had seen between the McCann Center for Brain Health COVID-19 clinic, as well as the neuropsychiatry clinic too. And even though kind of they sound kind of with different names, it's the same clinic. We both kind of multiple doctors staff both clinics. So I am in both. It doesn't matter. Just where the office is that is different. So as you see here on our screen, most of our cases were white women with some college, if not college degree, as well as graduate studies. They were the majority, like more than 75% of them were employed at the time, living in suburbia. We found that there are some comorbidities such as hypertension, cardiovascular disease, and asthma that were there, and a history of headaches or migraine at times of seizures prior to the COVID-19 was also prevalent, same as depression and anxiety. The reason you see like two categories here is from the confirmed to the presumptive is early on when the clinic started, there were people that could not get their test or did not have antibody testing. They were coming with COVID symptoms, so we took them on board. But then we followed the guidelines for all the clinics actually in the US that people are defined of having COVID either by positive PCR or positive antibodies. And we no longer kind of carry any presumptive cases. Of course, a lot of things could be said about this study. We did not have a control group. We did not have before and after. The sample size, even though was at 100, it's not that huge, but again, it was only at MGH, so there was a lot of selection bias. And people came to us for mostly fatigue and brain fog, and did same as well as headaches. For their neurocognitive complaint, those are people that were pretty much high functioning before that came to tell us we can't multitask, there are things we are unable to do. If a couple of people are talking, we cannot understand what they are saying. Our focus attention is very short. Some people came saying we have memory issues, but kind of when we really tested them, the memory issue was very much related to attention and focus. So they could not basically take the information in to later on be able to relate it. And very few came actually with no complaints at all. The patient's workup was at some point became very standard. We would do a mental health follow-up, check on their sleep, get them blood tests, their lifestyle recommendations. If they needed medication, they went through neuroimaging if they had any neurocognitive symptoms. And on neuroimaging, out of people that underwent brain MRI, so those are people that had something on their bedside exam neurocognitively, we had 2 cases actually of global volume loss. We had some vascular abnormalities with, now there is a question mark whether actually the virus causes also some inflammation around the vessels that we are seeing that way on MRI. And then some people had no findings at all. So the treatment recovery is that multidisciplinary clinic, quote unquote, on multidisciplinary. It does not happen in one day, it's spread out. But this is where people see speech and language pathologists, physical therapists, if we need any neurology subspecialty, OT, brain health, the SMART program, and if they need more around internal medicine subspecialty for any shortness of breath and stuff like that. So what we found actually is that when people come in to tell us that they have brain fog, that we need to basically go dig further, because brain fog can be a lot of things, can be attention, can be memory, can be anxiety, can be sleep difficulties. So whenever you have one symptom, please look for the other, because they are very highly correlated. And even though we started actually formulating that, even though the brain MRI may not tell us much, there is a neurocircuitry that is not working right between that subcortical midline up to frontally, which is basically causing either attention difficulties, focus issues, executive dysfunction, or in the extreme cases, people with like complete apathy, no motivation, ebulia, and then also at times being very confused and delirious. So with that, I'm going to actually give over to Mrs. Freeburn to basically follow up on what has been done in a rehabilitation and recovery.
Great, thank you so much for having me this morning. So my name is Jennifer, and as it was introduced at the beginning, I'm a speech language pathologist outpatient. We began seeing patients recovered from, I would say, moderate to severe COVID symptoms after hospital discharge last spring, early 2020. And then shortly after that, I would say around June, we started seeing more recovery from mild initial symptoms with this more long haul profile. So I'm looking forward to chatting about this today. Next slide. So there isn't, just next slide. There
Sorry,
isn't, that's okay.
Something is okay.
No problem. I'll start talking about it because it's just a quote. So
Okay,
there isn't a lot of evidence. That's okay. There isn't a lot of evidence at this time for rehabilitation for post-COVID cognitive symptoms. It's pretty limited, most likely due to timeline. But the emerging research definitely highlights the benefits of a multidisciplinary approach, which, as Zeina highlighted, is something we are certainly focused on here at MGH. And we see many patients in speech pathology for cognitive and language therapy with similar symptoms in a setting of other diagnoses such as mild TBI, MS. And so we take our approach essentially from there. And the research on that approach is emerging, and we too are collecting data and hope to be able to share that more widely soon. Next slide. So in outpatient speech language pathology, our therapy approach it's integrated across these sort of 4 pillars. So we start really with education. So understanding, helping patients understand what is going on. Metacognitively, what is the difference between attention and memory? So as highlighted previously, sometimes it feels like it's memory that's impaired, but it actually really lies in the encoding process. And so trying to help break that down and understand that feeling distracted or feeling fatigued or having a headache can impact how well we can remember something or how well we can participate in a conversation. So that high level education is a huge part of that. We also do a lot of counseling around self-advocacy and invisible injuries. So to Anne's really important point, a lot of folks experiencing post-COVID cognitive symptoms really do look fine, walking around, participating to a certain extent in some of their previous activities. And so we do a lot of counseling and education around the difficulties of that and advocating with family, with friends, colleagues, if you're attempting to do a return to work about that. Then we focus a lot on really practical strategies, which I'll talk about on the next slide in a little bit more detail, but very, very concrete ways of supporting some of these domains that are affected, like attention and executive functioning or language expression. And then as we teach these strategies, we also have a strong focus on carryover. So trying to figure out with the patient a plan for helping these strategies make their way into the real world. So again, to Anne's point, scheduling out the day. That's something that needs to be heavily integrated into your day-to-day life. That's not something we talk about in a therapy session and then it's done. You have to go home and use that every single day. And I would agree, it really is a job. It's a lot to implement these strategies. And so carryover support is a big part of that. And also really making sure that we integrate in whatever that individual patient's goals are. So some folks are very, very eager to return to work. Other people say, no, I want to take it much slower. I'd like to try to do something one step up in the community before I try to do something as complex as my job was before. And so trying to integrate those goals into carryover is a big part of this process. And then finally, care coordination. So I would say the referrals that I make, so coordinating back with the team to get additional referrals in post-COVID have usually been to add on another therapy. Most often it's actually been physical therapy, whether it's to try to reverse some of that deconditioning from the fatigue, or also sometimes vestibular. Patients will have vestibular concerns that seem like they might be contributing to some piece of the symptoms. And so referring back, and then of course, just re-coordinating with the team around any kind of updates that we have seen in therapy and progress, and then also advocacy. So when people are returning to work, making sure that we put reasonable accommodations in place, and that given that we get to know our patients fairly well, we can provide a little bit more context and potentially some of those recommendations for returning to work. Next slide. So just to think a little bit about some of the strategies that we do use and that have often been helpful for patients with these sort of long haul COVID symptoms. Given that primarily we're seeing fatigue and that kind of high level attention and executive concerns, that's really where you'll see a lot of these strategies lie. So for attention, as I mentioned previously, metacognitive awareness of demands. Why is it that the sound in the background when I'm trying to read is suddenly more grating to me now than it was before? And what can I do about that? Strategies to limit overload and overwhelm. So knowing that overload and overwhelm can lead to increased fatigue, we need to try to pace that out and try to limit how much additional distraction. Being in a group of 5 speakers might be too much sometimes. And so trying to limit that to one-on-one interactions, for example. And then identifying cognitive breaks. So what are some good strategies that people can use to take a break, whether it's mindfulness meditation or just simply deep breathing, taking a walk, something a little bit more physical, trying to find activities that allow for a cognitive break, unlike a lot of things we might think of as breaks like TV, looking at social media, et cetera, which truly don't give the brain a true rest. Executive functioning, motivational interviewing, and goal setting is huge. For anyone with dysexecutive symptoms, it's incredibly difficult to just implement lifestyle recommendations, for example. So make sure you take breaks in between your activities. Easier said than done in a lot of cases. And so really trying to work with scheduling, schedule in pacing strategies, ensure that you've got adequate breaks in there is really essential. Again, strategic scheduling, so using a physical, whether it's paper or electronic calendar to really pace out the day and plan the day, optimizing your best times and making sure you give yourself a rest during the worst times. And then external, everything external. And by that, I mean outside of the person's own brain. So writing down your tasks versus trying to keep them in your head, which for a lot of folks may be a big transition. So supporting that. And then for cognitive communication, things like language organization, planning, maybe a lot of folks weren't people who would have drafted their notes ahead of time, but it's something that they would do now if they needed to make an important phone call. So strategies like that, strategies for word retrieval, and really, in a lot of cases, helping to boost patients' confidence in their communication output and also their confidence in knowing what they can do to optimize their comprehension, whether it's for reading or for listening. So that is typically the approach we've taken. Again, a lot of it does come from a lot of the literature from other diagnoses. And my hope is that over time we start to certainly we see anecdotal patient response being very positive, and I hope that we start to see some outcomes in research as well.
All right, thank you so much, Jen. I'm going to continue. Okay, so I'm going to fly through certain slides. We could take more questions at the end, but just to give you more time to ask questions. We are really talking about the SARS-CoV-2, which is part of those human coronaviruses that we call the beta coronaviruses. The whole world actually had seen those viruses before with the epidemic of the SARS-CoV and the MERS-CoV like a few years back. So we kind of knew a little bit what was going to happen from the experience with those two other viruses. The SARS-CoV-2 virus basically now we know can have really immunological effects and non-immunological effects that are going to affect the brain. And we don't know yet if it is through going into the nose to that basically like cellular level of the nose and backtracking to the brain, or whether there is those inflammation around the vessels that I was talking about that could get into the brain, or whether basically there is what you have all heard about, that cytokine inflammatory process that basically can seep in through the blood-brain barrier where things are not very tight and affect the brain. Having said that, we're still unable basically to find like this huge presence of the virus in the brain, and I'll talk more about it in a later slide. So whether the SARS-CoV-2 does a direct invasion, as I said earlier, through the olfactory nerve or around the blood vessels, or through a peripheral infection, whether about the effect of how you're breathing and causing hypoxia and being in metabolic disarray, or your immune response, everything you see otherwise on that slide is basically brain related, whether those are kind of the midline structures around the anterior cingulate, or kind of the frontal lobe and then the mid forebrain, or even the thalamus, the caudate, and the cerebellum, causing all of that issues with that we are seeing with the amotivational effect, with the very much of the fatigue, the confusion, and at times even that complete delirium, to also not only as bigger structure, but mostly as in circuitry and more so neuroendocrine wise, right? Your stress hormones are up, that cortisol is everywhere. There is no way to calm it down, and then causing more of that cognitive storm, if I may say. So we've known that there are infectious agents actually that like the brain. We call them neurotropic agents, right? So they could invade the brain either directly or by para-infectious immune mediation, or there could be complication of systems. We so far, before kind of we do the bigger studies, we are unable to tell that neurotropism for the COVID-2. However, extrapolating really from the SARS-CoV and the MERS, we would think that, because I mean, it's the same family, maybe the COVID-2 will do the same. You will have like in the order of 10K patients that will have either central nervous system or peripheral nervous system complications. So this is what happened early on, right? So people had some symptoms, but then it took them a while to get the PCR testing kind of measuring at some point. But just to tell you, so in the beginning, it was a bit difficult to really detect that. But then later on, a doctor actually, Shibani Mukherjee, who is our infectious disease doctor, went further with her colleagues to really check on brain autopsy specimens. So those are patients that were very sick, went to the ICU, died out of COVID, and really the presence of that viral presence through multiple PCRs were at very low level. They could not identify a protein or an infected cell. There is one study out of Germany actually that identified some related changes, mostly in the cranial nerve nuclei and part of the brainstem, but very minimal pathology with a viral presence. So you can put a dye and then something kind of will show up as COVID-2 particles. Later, for some people with viral encephalitis that really were very sick and seizing, there was some CSF SARS-CoV-2 particles that were found, but those are very rare cases, still kind of a handful of cases in the hundred thousands of cases that were seen throughout the world. So neurological symptoms are major or minor. I am going to go quickly through that slide, but mostly what we see in our clinic are not the patients that came in after an inpatient stay that were very sick, but those are patients that were just sick, stayed at home, and yet they have those continued symptoms, such as not smelling right. And then people would say, okay, well, I have that persistently. I mean, we don't know yet how long it will take, but we definitely know that at least from the first SARS, that this lack of smell and the what goes with it, the lack of taste, can take a long time. The problem is that it impacts people's quality of life, right? Food is one of the primer into like pleasure, and people are unable to do that. That vascular dysfunction we talked about, I mean, people could have vascular events, and whether it is in their brain or in the kidney or in the lungs or in their bowels. The thing though is that in the lungs, you could see that much better, and we have better marker than what we do in the brain. So then this, what started being really anecdotal, is what we see now every day is that people started saying, oh, I have brain fog, and I have nightmares and fatigue. And then the brain fog was taken up by the local media. And then everybody then started saying, yes, of course, we have brain fog, to really then understand that those persistent symptoms are there, kind of what we are seeing now, rather than just the very sick patients that have been kind of in ICUs. So it's a myriad of manifestation. It's exactly what Anne was telling you. This is what we are seeing time and again. And some people also, it can exacerbate their anxiety and their PTSD. And for some, but that mostly in elder patients, that can go actually to very impaired cognition, to the point of delirium. And this is what the studies are going to show us. Furthermore, this question mark, is there any link between neuro-COVID and neurodegeneration, having that a baseline denominator being neuroinflammation, and we know how bad that could be to neurodegeneration as well. So the people in Britain actually picked up on that long COVID way earlier than we did. They call it long COVID, we call them long haulers. By definition, you should be at least away from 4 weeks of being infected to basically do that long hauler. So for the first 4 to 6 weeks, this is still part of the acute, and a lot of people do recover without becoming long haulers as well. And so in some studies, this is what I was talking about, increasing PTSD. We did not see that much PTSD in our sample, and maybe because people either under-recognized it or did not come up, basically describe it that way. But early on, like in studies done out of China when the pandemic was raging there, they felt that the PTSD symptoms were mostly around discrimination and people like, oh, you have COVID, and how bad that was, even like as a stigma picked up on that. So COVID and headaches, we find that there is a very good correlation between the two, especially with tension headaches. However, for people with a history of migraine, the long haulers headache basically are increased. And then we try also to address this headache as we are talking to our long haulers, because if you have a headache, you're not going to be able to think, right? And you need to sleep better to not have your headache, and you need to get to PT and massages and all of that to help with that tension headache. The seizures and COVID remain a very, very big question mark. Is it a coincidence? Very few cases actually have been reported. We do know that epilepsy prevalence is 1% in the population. So with that high prevalence, I mean, make it just a coincidence, or is it's still inconclusive? There's nothing also thought at this point that might lower seizure threshold. Of course, fever would, the stress would, but just there is no causal relationship. But there are people that, of course, would be at risk with compromised lung function if they are immunosuppressed, people with tuberous sclerosis, young kids with infantile spasms, or with like long history of seizures were more prone for cases of status epilepticus. So this is what is very important kind of in the last 2 minutes that we're talking is basically, is it a causality that we are talking about, or is it just an association? And this is where like really very big studies are still needed. And this is part of the NIH call for action, multiple sites to basically try to understand, is this causal? Is this because you had that COVID that you are having the symptoms, or is it just an association? One of those associations that I would like to talk about is like, for example, Guillain-Barré. And early on, people started saying, oh, we have a lot of like Guillain-Barré cases with COVID-19. But then throughout the pandemic, actually, those Guillain-Barré cases kind of remained the same, if not decreased. And then the COVID cases were soaring. So which ended up what the first observation did not lead to a causal relationship. So this is when we are talking about population, when we are talking about we have at that point a control, then a lot of things might change. So I love this slide. I mean, this is a friend of mine quoted as the Zeina slide, which is kind of true because we deal with patients that are very complicated in neuropsychiatry and in brain diseases. So having some observation with one line going through it may not be correct because you could have a variation of that line. So you need more observation and you need to have a rich set of excitation to really stimulate those nodes to understand the behavior. So if the excitation is not rich enough, you are missing stuff, and you might actually think that it is beyond association or just that observation that you had, and you would be missing a lot really. So in conclusion, there is no doubt that we have acquired a lot of knowledge about this virus and that the vaccine saved lives literally, but we still have a long way to go to understand the post-acute COVID syndrome. The multidisciplinary way is the way to go. It really takes a village, as Jen was saying. We call each other, we discuss cases, we reach out to really understand better, but that our patients are always listened to, and they are our best teachers. And with that, I mean, this is everybody that is working through that COVID clinic. And without them, I couldn't even present to you today or do our work. And mostly, thank you so much for our patients that trust us and want to keep the hope going and feel that they are doing better. My take on that is just give it a year and a season. Same as I would say with everything neurologically related. It takes a while for the brain to heal. It's not like everything else. And with that, I'm going to stop and open it up for questions. Thank you. I'll stop sharing.
Thank you, Zeina and Jennifer, and obviously thank you, Anne, for being so generous with all of us, for sharing your journey through this. So we have a bunch of questions, as I'm going to do my best to curate a few of them. One question that came up was, and maybe two, in terms of when we think about assessment, Zeina, and I guess to some, and Jennifer too, when you think about like how you assess individuals, are there some novel technology or novel approaches in using and thinking about assessment for long COVID, individuals with long COVID syndrome?
I could start, Jen, and then I'll also let. So there is no new technologies per se. I mean, still the same thing. At MGH, we have a newer MR machine that actually goes through very thin slices to see if there is any inflammation we can find, especially around those cranial nerves and then the brainstem. So we have asked, our neuroradiology colleagues have asked us actually to send them back those patients that have continuous symptoms. And there is an MR spectroscopy that could be done, but the problem is the limitation at sometimes is the insurance. They don't allow for that to happen as well. But then this is from our point of view. I'll let Jen.
I would say from my point of view, definitely no technologies. I typically use cognitive-linguistic assessments, pretty standardized. The one thing I will say in the setting of fatigue is that timing is key. So certainly for post-COVID cognitive concerns, we do try to specifically ask. Normally, you know, it's the system of scheduling. We just put people in, but timing is definitely a factor when fatigue is a factor as well. So being pretty pointed about that.
Great. Thank you. And then in terms of thinking about treatment options, so again, both of you, as you think about novel treatment options, the role, Zeina, you mentioned early on, just thinking about the role of conventional antidepressants, SSRIs or SNRIs, and sort of other classes. What have you found to be sort of effective in the treatment of some of the neuropsychiatric symptoms that have been as a part of the treatment?
We try to use a lot of the dopaminergic agent, and so and then also try to simplify pharmacy. So if somebody is depressed and has issues with executive dysfunction, we try to use Wellbutrin quite often for dopaminergicity. For the fatigue and focus, we go at times really straight to a stimulant at a low dose, like a low dose Ritalin. We have also, for people that could not tolerate a low dose stimulant, we have used things like Provigil or Nuvigil, and it does help with the fatigue, like it might help with the fatigue with patients with MS or TBI or something like that. For the headaches, and generally, if it is only tension headache, we would go through like the Tylenol, kind of that type of stuff. But we have found also that the low dose tricyclic can get people to do better at night and sleep better and have more kind of a restful sleep. We use melatonin very often for restorative sleep for people that actually are not taking any other medication. We haven't gotten really directly to SSRIs and SNRIs. Actually, I think one, they could aggravate headaches. We don't want that. And two, I think people need more because it is that amotivational syndrome, if I may say, that needs that cranking up, that the dopaminergic agent would be more helpful for.
Great. And Anne, I'm just curious as to your experience as you thought about some of the pharmacologic and non-pharmacologic treatment options that were presented to you. What did you notice in your own journey, recovery process?
Yeah, so I think the Wellbutrin helps, and it's interesting. I love Dr. El-Chemali's honesty. I wanted to come off of it because I felt okay and was feeling better, and she said no for the reasons she just described. I do use the melatonin and magnesium because I'm going through cycles. I'm at a point of having insomnia. So the melatonin and the magnesium, and I also do meditation, help. And those are really the only medications that I have been on.
Dr. Mehta, I also want to say that one part of our treatment is not only kind of referral to Jen, and Jen would be working with them. Another pillar is the Benson Henry program, the SMART program. And I think people do it, and really we get very good feedback. So I want to also put that as, even though it's alternative treatment, but it is a treatment that we really very much, I mean, it is a first go-to for us as well. I'll let Jen also say her stuff.
Yeah.
Yeah, no, I fully agree with that. And that's another one of the referrals that I would often circle back regarding would be the mindfulness training. And that's something that we do to an extent in terms of implementation, but for folks who would benefit from additional support, both within that community that Benson Henry offers and the support with the mindfulness training itself, it's certainly a great referral. I agree.
Okay. One of the interesting discussions that's happened has been around the comparisons between ME/CFS and some of the long haul symptoms that are seen in the post-COVID phenomenon. Any experiences or any thoughts? As I imagine Jennifer and Zeina, obviously you've seen patients who have been diagnosed with ME/CFS, and do they look similar or different in any way?
I mean, from my perspective, I think the trajectory just looks a little bit different for the post-COVID patients that I see. Though it is a slow return to activity, there is most certainly gains made all the time. That cycle of kind of boom or bust that just feels sometimes very, very persistent and unbreakable in ME/CFS. I think we tend to see this much more progress toward return to activity in post-COVID cognitive symptoms and cognitive fatigue.
I fully agree with Jennifer, and I really would like to start not comparing the two, because then actually it brings a very negative tag to post-COVID, because still the chronic fatigue syndrome is a very mixed bag. People don't understand what it is, and I would rather, I mean, from our point of view, not lump post-COVID into that, because then we are unable to explain it, and then it might drag, versus, no, this is an entity. Of course, the fatigue is there, but let us go after it just as in its uniqueness, so we could help that many people rather than stagger again for 10 more years for the CFS.
Right. And curious as to, from your perspective, just any discussion around some of the other integrative modalities that many patients may have pursued, for example, acupuncture or other. Have you, and Anne, from your experience, I think you discussed initially you had pursued Reiki therapy and other, but what has been your experience? And then I'll turn it over to both Zeina and Jennifer in terms of what they've noticed in their own experiences.
So I went through the Henry Benson program, which was really helpful in having access to the nurse practitioner that I went through it. I had acupuncture with Dr. Chang every week for months. That's decreased. I've also done craniosacral therapy, the Reiki, and massage. And I've actually been working with, I hired someone to do private yoga, and I've been doing some sensory work. And it's been helpful.
Okay. And Zeina, your thoughts? What has been your sort of, obviously, I imagine not much has been in the literature, but anything from just your own clinical expertise?
I mean, anything that can bring mindfulness and meditation, we we recommend that patients do. So that is very helpful. We are starting a study, and if that proceeds, then patients will be able also to address that, which is using neuromodulation as part of that therapy, with like putting on TDCS and stuff like that as well. But this is, again, it's just still within the research part for people. So people, if they come and say, can I do acupuncture? I always say, if you could try anything you want, and if it helps, just continue it. If it doesn't do anything or gets you worse, then stop it. So I haven't had like any big successes with just acupuncture or not acupuncture, but it depends on what people would want to do.
I would fully agree. And just to add two more, what I would consider holistic therapies that I've heard people do, not necessarily alternative, would be return to physical activity. So because of shortness of breath and all sorts of other things, more so having sort of a personal trainer or a training coach to do that has been incredibly valuable. And then also nutrition. A lot of folks have turned to try to implement some of the more holistic health recommendations. And I fully agree. It's not just one thing, it's sort of everything altogether.
And just to, I'm just going to probe just a little bit. When you say nutrition, you mean what are you exactly referring to?
Like seeing a dietitian or a nutritionist or a practitioner who does holistic health and also makes nutritional recommendations, that sort of person.
And if I may add to that, Darshan, I think part of both kind of the exercise, moderate, I would say mild to moderate, and then people would increase because you don't want them to go back onto their level of exercise. And the nutrition is basically from an angle to decrease neuroinflammation. And we know that both do decrease neuroinflammation. So generally holistic dietitian with less, that actually recommend the less neuroinflammatory diets would be the way to go.
Okay. Last question, and this is maybe a provocative one. Are you seeing any symptoms in individuals who are taking the vaccine? And do you see these post-acute symptoms in individuals with the vaccine?
So we have kind of made a little bit of that boundary that the post-vaccine patients will go to see infectious diseases and their primary care physician. So we haven't had that exposure for me to really talk about it in grand rounds, but I don't know if Jennifer has.
We're not receiving specific referrals for that. I know that a lot of the folks experiencing these long haul symptoms have different experiences with the vaccine. So like a return of fatigue for a couple of days in a short-term basis, but that's really all I have seen.
Okay, well, I want to just thank Anne, thank you so much for your just your honesty and vulnerability with all of us. We're really, truly grateful. And you know, this can't be done without that. So thank you, thank you, thank you. Zeina and Jennifer, thank you so much for just your expertise and the wisdom you bring to this conversation. Again, this is really emergent topic, and obviously, hopefully we can invite you to come back. And again, to all of you in the audience, please join us next month. We're going to, our grand rounds will be Dr. Adam Reinfleisch, who will be talking about basically what does it mean to build a brand new medical school through an integrative medicine lens. And we look forward to having you join us. Again, thank you, everyone, and we'll look forward to seeing you next time. Be well.
Thank you, and thank you again.
You're welcome. Thank you.